Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient with advanced HIV who develops a few weeks of headache, confusion, seizures, and a new focal neurological deficit. MRI shows an enhancing brain lesion. In MRCP, the key question is this toxoplasma encephalitis, or is this primary CNS lymphoma? Primary CNS lymphoma in HIV is an AIDS-defining Epstein-Barr virus-associated diffuse large B-cell lymphoma. It usually occurs with severe immunosuppression, classically when the CD4 count is below 50 cells per microliter. It presents as one or more focal mass lesions within the brain. Let's simplify the pathophysiology. Severe T-cell immunosuppression means the immune system can no longer control EBV-infected B cells. So the sequence is low CD4 count, impaired EBV-specific cytotoxic control, EBV-driven B-cell proliferation, and finally malignant lymphoma within the central nervous system. Now link that to the symptoms. A malignant lymphoid mass infiltrates brain tissue and causes surrounding edema. Infiltration plus edema causes focal neurological deficits, seizures, and raised intracranial pressure. So headache may reflect raised pressure. Confusion and cognitive decline reflect cerebral dysfunction. Hemiparesis, aphasia, or visual field defects depend on the site of the lesion. Seizures occur because the involved brain tissue becomes electrically irritable. The lesions are typically deep or periventricular. Important sites include the corpus callosum, basal ganglia, and thalamus. This deep location is one of the clues that should make you think about CNS lymphoma. Clinically, the presentation is usually subacute. Patients may develop headache, confusion, cognitive decline, focal neurological deficits, seizures, and sometimes cranial nerve palsies. B symptoms are less prominent than in systemic lymphoma, so do not wait for fever, night sweats, and weight loss to think of this diagnosis. Diagnosis is based on contrast MRI, clinical context, and tissue confirmation when needed. MRI usually shows a solitary enhancing lesion, which may be ring-enhancing or homogeneously enhancing. In AIDS, lesions can also be multiple, which is why imaging alone can be misleading. The key differential is toxoplasma encephalitis. Toxoplasmosis usually causes multiple ring-enhancing lesions in the basal ganglia, often with a CD4 count below 100, and toxoplasma IgG is usually positive. Primary CNS lymphoma is often solitary, deep or periventricular, EBV-associated, and classically occurs with a CD4 count below 50. CSF EBV PCR can support the diagnosis, but it is not definitive. Brain biopsy remains the gold standard, especially if the imaging is atypical or if there is no response to empiric antoxoplasma therapy. Management starts with antiretroviral therapy. ART should be started or optimized. If the patient is fit enough, treatment is usually high-dose methotrexate-based chemotherapy. Rituximab may be used, although the evidence in HIV-associated primary CNS lymphoma is less robust. Corticosteroids reduce edema and mass effect, so they may be needed if there is urgent raised intracranial pressure. But the exam trap is that steroids can shrink lymphoma and reduce the diagnostic yield of biopsy. So avoid steroids before biopsy unless there is urgent mass effect or raised intracranial pressure. Whole brain radiotherapy was used historically, but now it is often reserved for refractory disease or for patients who cannot receive chemotherapy because of the risk of neurotoxicity. If you remember one thing, remember this. In advanced HIV with an enhancing brain mass, toxoplasmosis is the key mimic, but a solitary deep periventricular lesion, very low CD4 count, EBV association, and poor response to toxoplasma therapy should make you think of primary CNS lymphoma.